So without wasting much time, let's give a kickstart to this 3-day session, and we start with Colonel Chitalkar, sir. So, sir, I request you to take the control for next 15 minutes, and please start your presentation.
Thank you, Amol. I think it's a great pleasure to be part of this workshop on advocacy. And actually, I am just standing between me and the wonderful panel put together by Prabhat Sinha. I'm only going to illustrate one issue, and that issue is some unmet needs of the young people. And I'm actually choosing not typically a cancer, but a combination of benign hematological disorders and cancer. And may I be permitted to share my screen now? Okay, there. Yeah. Okay, there we are. Thank you. So we will take this. Firstly, I'll bring you greetings from the Sri Aurobindo Institute of Medical Sciences, where I work, and it's in the heart of the Western Madhya Pradesh, and we cater for something like 17 districts and some 22 million people. And we'll quickly run through what we actually want to see is blood disorders in the burden of Madhya Pradesh, the sickle cell disease, aplastic anemia, leukemia, lymphoma, and this is the demography roughly. There are 84 million people. Per capita annual income is as little as 80,000 to 1 lakh. Annual cancer burden is something like 73,000 as per the 2020 Globocon. And so we have, as 6% if you take of all the cancer burden, there are approximately 4,300 young people between the age of 15 and 29 are suffering from cancer in this state of Madhya Pradesh. And a sixth of these are hematological cancers. And what we see in our center is roughly only about 6th or 7th part of it. So what is lacking is access, awareness, age-appropriate care, and advocacy. This is just a map of we'll start with the illustrative disease of sickle cell disease. A large number of heterozygotes and a very small number of homozygotes, but they are concentrated in two parts, northeastern Madhya Pradesh and southwestern Madhya Pradesh, in about 10 districts. And what do we have? We have 9 qualified hematologists in 5 cities. And we are, like, just to give you an illustration, something like nearing about 100 patients we saw in the last 6-7 years. Many of them were in some crisis and so on. And yeah, you can see orthopedic disability like avascular necrosis in the femoral head, 9 patients. Hip replaced in more than half of them, and so on. So we actually gradually, a period of time, we have started addressing the problems of this benign disease. The TYAcan Foundation, this is part of the mandate, not only cancers between the 15 to 30 years age group, but also the catastrophic hematological disorders which are managed by transplants. So exchange transfusion is one of the modality. We have done almost a third of them have been subjected to exchange transfusion, and we have saved them from the acute crisis. And then most of the time we do it manually in the ICU, and we managed to pull them out of most of the crisis. 4 deaths have happened after the exchange transfusion, but not even one of them was related to the exchange procedure. Most of them survived. We can see almost 7th or 8th of all sickle cell disease actually came with pregnancies, and we followed them through with normal deliveries, some even LSCS, cesarean sections, and so on. So what we actually need is awareness, access, advocacy with the government. And a statewide project is actually an unmet need. So we will come to aplastic anemia, another catastrophic hematological disorder of the young. 79 patients of aplastic anemia have been seen in this our center. 21 of them are followed up regularly. 10 received ATG, and 11 of them out of 7 about 7 are alive, and for a duration of about 41 months median. 2 allotransplants are done, both matched sibling donors, and at least one of them through the Ayushman scheme. I'll come back to the subsequent one. And 5 patients out of such a big number finally were HLA identical siblings. So all this took a lot of effort, financial support, advocacy, counseling, and so on. Aplastic anemia remains a silent scourge. Diagnosis takes a minimum of 6 weeks. Repeated transfusions are required. Trial-lineage cytopenias are seen. Autoimmune disorders usually accompany. Opportunistic infections like staphylococcus, pseudomonas, tuberculosis, and even mucor is quite common in opportunistic infections in aplastic. Several deaths occur, and most of them, the young people die. And I always tell the patients and most of the bystanders that I consider aplastic a worse disease than a cancer in the young, because we are doing much better with cancer as we compare to aplastic. So again, it's an unmet need. And this package, which is there at the bottom of the slide, we actually devised with the Ayushman Bharat Niramayam of Madhya Pradesh. We actually devised it, and it's the last two letters of the code shows MP, that is actually specific to Madhya Pradesh. So National Health Authority has approved the Madhya Pradesh package, and we actually helped design this. And it's a proper package, and we are able to give anti-thymocyte globulin through it. Here's a patient, young boy, who actually had a transplant, and this is on the last day of his transplant before his discharge. And this was supported by the hospital, the TYAcan Foundation, and with the Ayushman funds. So allogenic transplants are a standard of care below the age of 30, but it's easier said than done. And anti-thymocyte globulin, of course, remains the standard of care. The equine product almost achieves 60 to 70% responses. Small percentage will die. 20% will progress to either acute leukemia or even myelofibrosis. And restoring hematopoiesis and transfusion independence is the first objective of this therapy. 4 to 5 days regimes are required, followed by steroids for serum sickness. And to that we add cyclosporine for 3 to 6 months, L-thrombopeg and component support. But the cost is not less than an allogenic BM. So that's where the catch is. So it's a difficult issue to basically choose between the two, especially if you don't have a HLA identical donor for a patient of aplastic anemia. We come to acute leukemia in the young. We've had two epochs. Just when we started the DM program in 2013-14, so we got the first 3 years data about 66 patients and the next 3 years data of 73 patients. What you see is abandonment rates were about 16% in the first epoch, and they came down to about 10% in the second one. The induction mortality was 12% and then came down below 10% in the subsequent years. The complete remission rate was also started rising. Here I'm adding both ALL and AML, of course, and completed therapy also is a significant number. And now there are many of them are now on survivorship program with the help of the survivorship vertical of the Indian Cancer Society under the Picasso project. So progress in leukemia lymphoma is occurring by leaps and bounds, and you can see how our DM program has actually in the community, how it has gradually increased the acceptance, the facilities, including flow cytometry, cytogenetics. You can see by 2017, we were able to start giving complex protocols, including high-dose methotrexate, BFM 2002. And now we are able to do in-house flow, in-house IHC. And over a period of time, now we have a seamless pediatric TYA adult transition and shared care algorithm and altruism. And most important among all this, of course, continues to be advocacy with the government, advocacy with the school teachers, advocacy with professors in the colleges, advocacy with employers. And that's what the subject of the next 2 days deliberations in the Congress is going to be. Allogenic transplants or AML also we've done, even a haploidentical transplant. All this was possible because we were able to advocate with government, with the collector's office, with Ayushman and so on. So here is an example of a haploidentical transplant done way back in June 2017. And the patient remains well. He's a farmer. He takes a pickup truck and goes the whole day doing farming, and he's very busy. But I'm sure today he's locked in and he's actually listening to this program. Dilip Aleria, he was felicitated on the day 100 of his transplant by the collector of Indore. So autologous transplant, quite a few have been done again for a variety of conditions. But another procedure, leukapheresis, when you have very high counts, it requires a donor. We need to actually again advocate that nothing is going to happen to you. You will be on the machine only for 2 months, 2 weeks, rather 2 hours or 3 hours, and your leukocytes will take care of the neutropenia of the patient. Granulocyte transfusions also we give for profound neutropenia. So here's a symposium we had in January 2020, just on the Vivekananda's birthday, just about 2 months prior to the major lockdown. And we used to always feel that our youngsters who undergo cancer care are not eloquent enough. We used to think the youngsters and the survivors from the metros are more eloquent. They can speak everything. But here's a panel consisting entirely of the survivors of Ujjain, Indore, Mandsaur, Ratlam. And they were so eloquent that they kept us spellbound. And that was a moment of reckoning for our program. It had run for 6 years, and here it was. Our survivors are now able to speak confidently in panel discussions. So I think, ultimately you require to empower, you require to connect. So here is a collaboration between NGOs in Aurobindo Hospital. Ugam of Bombay, Can Kids of Delhi, and TYAcan of Indore, and so on. So we all got together. So here's a team consisting of academia meeting social entrepreneurship. So last but not the least, I must congratulate Prabhat Sinha, Amol, and for bringing us all together. And what we really need is the unmet need of advocacy we want to now explore. I think this is a great opportunity to have such a galaxy uh, of participants. Thank you very much. I'll give back the screen to Colonel Amol Patel. Thank you so much.
For the audience, I just have to tell about Professor Chitalkar sir. He has always been considered as out of box person. It's not about just thinking, it is out of box person. As an individual, he is thinking, his thinking is somewhere we stop and his thinking start. He started this AYA concept much earlier, I believe, than even the UK people were not they were in so formulating the guidelines for the how the AYA clinic should be